That's your office, Joanne.
You do recognize it or you don't?
I did not, I said.
7 people.
I just go into random offices. I can't work from home anymore. I'm knocking on doors at this point, I swear.
I know the feeling.
Yeah, same here.
I have a new coffee shop that is going up like a block and a half from me, and I'm like, can't wait. It's sad.
Us extreme extroverts just can't stand it.
That's
It's gotta
right.
have background noise.
It's like the
moving, doing
huggers.
things. Pardon?
It's like the huggers of the world. we're not doing so well. For those just joining, we're going to give it a few more minutes. If you want to take a moment to type into the chat function your main reason for attending today, that would be great. I'm going to do this for
Where's the chat?
Oh, hi, Jeremy Lapidus. I see you.
Hi there, Joanne.
Yay.
How are you doing?
Alice asked about Alice L this morning. So it's got to happen.
We'll get our kids together for a play date soon.
just so everybody knows, Joanne knows everyone. Everyone.
Let's all play with my kids, please. I'm so sick of them. Okay. There's 107 now, Lisa. Just FYI.
So do we want to get going? Yes? I see a lot of shaking of heads, so that's awesome.
I think we can. We're waiting for there was a number. There was like a good more 50, but we've got enough here.
Sure. All right. So with that being said, let's get started because an hour and a half goes really, really quickly, or 2 hours goes really, really quickly. And this is a really hot topic and something that I think everybody is very passionate about. So I wanted to take a moment to welcome everybody to this SDOH workshop, What's Data Got to Do with It? And this is the healthcare provider teams session. You can see that this is our agenda. For those who don't know me, my name is Lisa Nicolau. I am relatively new to MyHIN. I came in just in the summer and quickly found myself as the program director for the new MyHIN Social Determinants of Health program. We'll get to some more introductions a little bit later on, but just so you're aware, our agenda, we're going to spend the bulk of our time today really trying to get down to those bigger conversations that really represent your perspectives. It's not about what we know. It's really about what is coming out of the communities and the stakeholders within the community. So we really want to understand that perspective. We really want to be able to allow those opportunities to provide the feedback and really work towards a collaborative solution as to how this moves forward. I think everybody recognizes the potential that it holds. So you can see the agenda, housekeeping items. This is a conversation. This is not meant to be an educational session. There's a couple of slides that kind of give us some baseline. But this is really about kind of an open dialogue. So feel free, do not feel like you cannot unmute yourself and jump in. This is not formal. We want to hear from you. All of our team wants to hear from you. So please jump into the conversation, whether that's in the larger group or whether that is in the smaller breakout sessions. We want to give everybody an opportunity to be heard. Next slide. So again, this is our program team. You are going to see these faces resurfacing. We're not going to take up a whole lot of time because I think most people have heard of us, but recognize that this new team was brought together. There is that increased emphasis. The reason MyHIN is put this program team together is that it gives us a very diverse mindset. It allows perspectives to be coming in from the technical as well as the experiential and the medical and the social care provider range. So really kind of trying to bring all of it together to better serve this space, this data, this care care process, and moving forward. We want that diversity. So we're not going to take time to kind of go through all of those, but just recognize these are the folks that are here to meet your needs. Next slide. Today's session, as well as the entire workshop series, was really conceived of and thought of as a collaborative approach. We really wanted to reach out to all of as many stakeholders as we could, get buy-in on kind of what is it that's important to you? What is it that you want to hear about? So recognize that these statewide agencies have thrown their weight behind this idea of bringing together these sectors to really understand their perspective. So we thank you for your partnership. We look forward to ongoing partnership. Next slide. Why are we here today? Today's purpose is really just that. It's a series of conversations. It's one of a three-part series. We did community-based organization and social care provider teams last week. We're trying to keep those sessions pure to kind of the boots on the ground, like who's actually doing the work, because what may have been missing in the past is really that boots on the ground perspective that really allows solutions to develop that stand a chance of working in the future. So last week's session, Joanne, we had 120 people attend. Okay, 120 people attend from community-based organizations versus, you know, not as many the last time we tried to convene this type of session. So really getting greater feedback, greater emphasis on it. Today's session is healthcare organization, healthcare provider teams, and next week we have our government entities workshop. So we really look forward to that conversation. But it's an opportunity to provide that boots on the ground feedback towards that statewide future state. Next session, or next slide, please.
I'll take this if you want, Lisa.
Yep, go ahead.
I don't, I could not. Here's just something. So why MyHIN, right? Well, MyHIN is in this crazy position to be a sort of neutral infrastructure. You don't think about your pipes when your water's coming through and it's clean, right? When infrastructure works well, it is supposed to disappear. MyHIN is a nonprofit, not owned or controlled by any one sector, here to provide the infrastructure for legal, secure, meaningful data exchange. And I think that the most important thing that we need to recognize here is that, you know, technology is a tool. It's a tool for data to flow. Data is supposed to communicate. Data is supposed to make human beings better. But human beings are the energy behind this. And there are technical infrastructures for sure that are complicated in some ways, but the most complicated stuff is the human infrastructure. And that's why you're here today. So thank you for being here. I want you to understand sort of where MyHIN's coming from. We have a number of stakeholders, as you can see, and almost all of these stakeholders are interested in understanding how to use social determinant of health data to make people better.
In terms of who's attending today, just take a look at how crowded this slide is. This represents the level of interest that surrounds this topic, and I love to see the fact that this is as crowded as it is, and the energy that is behind all of this. So again, the wide range of participants, we thank you. Next slide. So I think everybody's seen a variation of this slide at some point in time. The really big important piece of this is that healthcare is not all about medical care or all about What makes up an individual's overall health involves the community. It involves social care. And those two things have to come together if we're going to see the type of improved health outcomes for our patient population, for our Michigan citizens, that I think everybody wants to see. So recognizing the importance that those socioeconomic factors and physical environments play is critical. And I don't believe that within this specific space, that is a new subject at all. That is not new information. People within this space, this healthcare provider space, have known this for a long time. It's how to incorporate it and how to move forward with it that is the barrier. Next slide. So just to clear up a little bit of terminology. So when we talk about social determinants of health, it just seems like an all-encompassing thing. Like, it's how in the world can we possibly address environments in which people live, work, and play? Those are really, really big and complicated subject matter. So when we apply just a broad label of social determinants of health, it can seem completely overwhelming. So it takes up a lot of individual things. When we are talking about SDOH data, we are actually talking about social care data, identifying what needs our individuals have, identifying what type of goals that individual has to be able to meet those needs, what interventions are applied to those needs that allow outcomes to happen, which outcomes or which interventions actually provide greater outcomes for those individuals. Getting down to a difference between social needs screening data and social problem diagnosis. So you can identify an individual has a utility need, but which of those 5 utility needs really best describes what their problem is. So being very articulate about what that is. So all of that really is what we are talking about when we talk about this broad category of social determinants of health. When we as a program are going to talk about this going forward, we're going to be very specific about this being social care data. Next slide. The goals for the SDOH program, I think it's really important to understand that our program here at MyHIN is really about enabling the collection and exchange of social care data at that point of care. And it's there to support different needs, to support that cross-sector care coordination, as well as to provide that overarching comprehensive data for that population health improvement. And how do we, so starting that data flow as specific to care coordination and being able to get people to the services within the community that they need to get, but then being able to surface that data for that greater need. Like, how are organizations utilizing this data? Can we get that information to those organizations to be able to make good quality decisions? What do they use that for? To be able to define how we spend scarce resources, what provides the biggest bang for the buck. That is not our decision. That is our goal, to get that information to those organizations so that they can make those decisions. And we do that by developing and implementing content and exchange standards for what we talked about, that social care data, social needs screening, social care problem diagnosis, and social interventions. Any questions about that right now? I'm going to stop and just let other people talk. I'm hoping that a lot of that is reviewed.
This is Julie, and that, although that answers the question I had, that really wasn't a very well articulated question that I had. So the question revolves more around how will people use the information to avoid bombarding patients. For example, you know, that social need that we talked about, maybe they need food. How do we avoid 10 different programs trying to, you know, help that same patient who may have already been addressed by one organization? How do we stop the rest of it? You know, how do we make that workflow work throughout the continuum.
Agreed. And that is something that is, we're still trying to figure that out. So we can get the information in. How do we push that information back out across those care teams to be able to make everybody aware that that need is there, so that we're not rescreening people 25 different times, asking them the exact same questions? How are care team members then able to see who's ultimately servicing that individual, so that that duplicative effort doesn't happen? Is there anybody else from my program that would like to take a crack at answering that? Dr. Klinkman, maybe? You're on mute.
Oh no.
Dr. Klinkman, you're on mute. Can you?
Double. Let's let him figure this out.
Yep.
Figuring it out. I was just responding to
Yay!
it. Sorry. We'll get into that a little bit more in the last few slides, and certainly during the conversation. And sorry, I'm doing double duty here. I'm responding to messages from patients as well as this session, which is typical for COVID. Sorry.
For sure. Julie, we'll log that one in, and feel free to jog us back if we don't answer that question sufficiently for you.
And Julie, there was a lot of conversation. We'll share it with you at the CBO workshops, because the other part was like, how do CBOs communicate their capacity at any one time to be able to help somebody at any one time, on a specific intervention? And also, another question is why would somebody be sent to one organization over another organization? Is there any previous existing active care relationship there? Like, do they know somebody? So there are a lot of questions around this, and the CBOs were really starting to think about it.
That's great to hear. I was unable to attend that one, so that's good to hear. Thank you.
We're sending out, we got to put together the recordings and the synopsis white paper, but it's all coming to you guys.
Okay, so
For
you're
sure.
also going to have to explain what a CBO is, because not everyone on the webinar will be familiar with that term.
I'm so sorry, community-based organization. Otherwise, you could also know them as social service care providers. In our community-based organization workshop, we invited faith-based congregations. These are the people out in the communities that have come together to help people, whether they are totally business minded, or whether they are a group of volunteers that are trusted and have the relationships. These are the people that are providing social services within the community.
Yeah, folks, in a few minutes, you'll have some pictures, and we'll walk through this so you can see how this fits together and what roles a community organization might play in a mature system. So great questions, and we're anticipating where we're headed. So good job,
sure.
everybody.
Let's go to the next slide and see if we can't delve into that conversation a little bit more. So just, again, a lot of folks may understand kind of how we got to this point in time where we're talking about social care within the context of healthcare and healthcare within the context of social care. But in order to really kind of take a look at how all of this emerged, and we're talking about and how that need for that data really started, we have to go back quite a ways, back to the start of those value-based payment methodologies that started back in 2005, where we went in healthcare started the transformation from fee-for-service, see one, do one, get paid for one, within healthcare, to see one, do one, get paid because somebody's health is maintained or improved because of those interventions that are being provided. So it was really an effort to kind of look and better understand what was happening. But that took movement within our healthcare structure to really move towards a data use organization and building in all of that capacity, whether that's standardization of individual data, so that that data can be utilized not just within that organization, but shared across organizations to be to provide that learning mechanism, and to really evaluate who's doing what and well and why. So over the course of 15 years, you saw multiple demonstrations come in from the MyPick days of care transformation. It took a lot of time, effort, and dedication to bring organizations within healthcare up to the point where we're at now, where we're ready to move forward and be able to partner effectively with community-based organizations. But it's really only been in the last five years where community-based organizations have really been brought into this. And at the same time that all of this energy and attention was focused on social care, not that far after, we had COVID hit, and COVID really highlighted a lot of those gaps in care between healthcare and social care, and the discussion about health equity and how do we improve that health equity. So there's a lot of work and a lot of groundwork that goes into preparing organizations to get to the point of being able to exchange and value the data of social care. We're still in the process of doing. So recognizing that is a true transformation. Next slide. Again, just highlighting the effects of social care and the importance that social care plays. We are seeing it play out in terms of health outcomes within COVID, seeing that populations with many needs and unmet needs certainly suffer greater consequences when it comes to the pandemic. But I think that this applies all the way through in terms of chronic illnesses as well. So that's that equity gap that we are seeing. Next slide. And I think Dr. Klinkman, I believe this is where you may take over.
So good morning, everybody. For those of you who don't know me, I'm Mike Klinkman. I'm a family doc at Michigan Medicine, professor of family medicine there. But I've been working with MyHIN kind of since the SDOH program launched. So been around the block a few times with this work. And what I thought we'd do for maybe the next 10 minutes or so is kind of a flyover. We're going to look at how MyHIN's approaching this task of better connecting around social care data. And what you see in this first picture is the basic pieces in that strategy. We're trying to build on the foundation of a common care model, which I'll explain in just a second, to support cross-sector care coordination. I think the main thing we're trying to do is make it better for people on the ground to share information needed to support care for a human being. We're trying to work with the National Gravity Project, and for those of you that don't know that, I'll explain what that is in a second, to develop standards for moving that information and what that information should be. We're going to use MyHIN's existing tools. So those of you working with data right now on the healthcare side, some of the things that we're trying to build into this work, you should already be familiar with and have your experiences with, so it may be a little bit easier. And finally, we want to work with IT vendors that are willing to work to these standards so they don't have to keep jumping through hoops and twisting to figure out how to connect every single vendor in this space and convert their information so that it can be moved. This is going to be a multi-platform world that we're living in, and we're going to have to adapt to that. Next slide, please. This is what I mean by a care model, and this is the one of the Gravity Project, which is a national collaboration looking to develop standards for content for social care information and standards for exchanging that information. The group started by figuring out what a care model should look like for human beings. So you've got the person in the middle, you've got a clinical medical care team on that upper right side, you've got a community care team, which are composed of community organizations who are providing social services largely, also in this cycle on the bottom left. And the idea is kind of familiar to those of us in healthcare. We screen, we diagnose, We try to set goals with the people that we're serving, and we create interventions or treatments. So pretty familiar model. And next slide shows everybody's spot in it. So the next picture shows where kind of the bulk of the work in healthcare is on screening. Many of you out there have been doing social determinants of health screening for some time. Identifying the problems or creating a diagnosis so that we know what those problems really specifically are. Working with that person or patient as you're seeing them. And sometimes some of you are working on referring people for services. Next slide. On the flip side, the people that are getting your requests for help are the people working in social services in communities, whether this is chaotic, random, one-offs, special arrangements, or whether there's an organized system to accept your requests for help. And so the social services folks work with people primarily on making sure they know what the problem is that needs to be addressed and how and what services to provide to address it. They don't so often do screening, although they are increasingly doing that for other problems, things that they don't take care of in their shops. And they may refer to other social care organizations if they identify additional needs. So
Just for the record, Dr. Klinkman, I hate to interrupt you, but you know, the community-based organizations wouldn't say necessarily that they are doing screenings. But I will tell you that they don't, but they are asking people questions about their life to see which, you know, where they can give them a soft spot to land. So while they wouldn't necessarily.
So yeah, absolutely right. Next slide will show the kind of final piece in the puzzle, which is what we have called second level users. These are the folks in health plans or the folks in the payer side or public health that are, or communities that are trying to learn from the information about the care that occurs in their own place, to do risk adjustment, to do benefits adjustment for what services they need and want to support, to do resource allocation in their communities, and to look at the effectiveness of what gets done. So there's a cycle here, and population health uses for this information are pretty important. Next slide. Questions about just that general model and how people fit together. Wow, clear. This picture shows how bit by bit we're putting standardized language into our systems so that we can better communicate. So on the sort of care team side, on the right, you've got electronic health records that have the ability to code in LOINC and to do ICD-10Z codes and to use SNOMED CT to come up with standard ways to describe social problems. On the other side of the fence, you've got increasing numbers of social services navigation applications that are using sometimes LA211 AIRS taxonomy to provide a description of services that they provide that you can map to the problems that can be identified on the medical side. This is a way to try to make sure communication goes forward. And this is all just sort of underway, so we don't have any final answers about this stuff. Next. This figure, I think, provides a way to look at the relationship between healthcare folks and community side folks. On the healthcare side, that's the red part. We've been increasingly doing social determinants of health screening. We are trying to work on ways to standardize and make better diagnoses about social problems by making the ICD better. That's part of the work of Gravity. And we do some follow-up. The flip side of this, or the complement, or the necessary partner, which is what I prefer to call it in this, is the community sector, who often do a more clear assessment of what somebody's problem is once we identify somebody after a screening test. They figure out how best to provide services in the context of the community, and they do follow-up. And they can handle much of this stuff on their own without healthcare needing to be involved. But sometimes, and increasingly, we're being asked in healthcare to do screening so that we can identify, proactively address things that may have a long-term impact. And I see a lot of things coming in in the chat, which is great, are able to talk about which types of vendors. Yes, there are lots of vendors, and we can talk about that both in our breakout sessions in here, but there are right now at least 8 or 9 different social care navigation vendors that MyHIN has talked to because they're interested in working in this space. But the conversation so far has been, can you work with us to develop standards and follow standards so that we can move information? We don't want to adapt everything we do to fit your vendor's preferred workflow. We want you to work with us so that this stuff can interoperate. And you're right, many CBOs don't have these codes. And we're working with the CBOs to help them understand the model, to help them see if there is value to them for learning how to code things so that the information can go back and forth. And there are huge adaptations that we may need to make in workflow for rural or remote areas, but we may not need to make any major adaptations in this general outlook for how these sectors should fit together. The Gravity Project is addressing the needs of what rural, low technology, smaller organizations can do to be part of this kind of an environment. And yep, Diane Harper's comment's really good here too. There is all sorts of sensitive information that may be addressed as social problems become known or are screened. And those sensitive topics are also worth a separate approach or a way to try to figure out how to protect some information so that it isn't broadly shared. And that's a whole nother conversation that we will be having around data governance and sharing and consenting. That's critical stuff. We're just getting there. So thank you. These are perfect questions. And we're trying to keep this high level right now so you understand the why and the sort of how. The specific pieces of how this fit together are the things that we want to work on collaboratively over the next months. Next slide. If I can have your attention for just probably 2 or 3 more minutes, I want to give you an idea of where things are in Michigan right now. So let's move to the next slide. This is kind of what we know. We have looked at building these things called Community Integrated Health Networks, or CIHNs, which are very, very similar, for those of you that participated in the SIM project, to what we called Shires. This is an organization approach that brings everybody together in a community to do cross-sector partnerships. This is a framework that's been published, I think, in 2020 by the Administration for Community Living in partnership with CMS. So this is kind of a model. It's got health partners. You guys are at the top left. You've got network lead entities, which are the group that kind of comes together as a backbone that we called in SIM, and then community organizations that do a large part of this work on the ground. Next slide shows kind of a view of how this works in one place. So in West Michigan, beginning in 2018, we worked to pull together the health systems, some network lead entity that emerged, HealthNet of West Michigan, which is a social care navigation partner, in working with the West Michigan Population Health Council to be kind of the core of this, and then several key community-based organizations. Here's where we're at, though. This is probably worth spending a second on. There are 3 health systems using Epic. Find Help, Signify Health are 2 vendors in this social care navigation space that are both already active in the community. We're using the 211 resource directory. HealthNet is trying to design its own technology platform to move things around. And Healthify, which has been trying to build what they're calling the Michigan Community Network, is also active in Grand Rapids. So we have to pull together all these different vendors in a space to connect to one another. Governance, still to be worked out. Funding, still to be worked out. But this shows the complexities of doing this work. And most of us on the healthcare side, thankfully, won't have to deeply dig into all this stuff to make this go. Last slide before we kind of break. I won't spend much time going through all of this, but this just shows these are the areas in Michigan that we are aware of active work being done to try to do this cross-sector care building. Several of these were the SIM shires that some of you participated in and most of you may know about. The blue is the areas that MyHIN knows about, or that those of us working on the social determinants of health MyHIN team know about. There may be others, and I apologize in advance for missing your work if we don't know about it. Tell us about it so you can be on the slide. But each of these shows a large amount of work to bring together healthcare and community organizations and the IT backbones and the IT platforms active in the community. And on the red, you see how the health plans, Blue Cross, MDHHS, the Medicaid health plans, have also been trying to dig into this space and participate from their end. This stuff is a huge alignment issue because everybody wants to move forward. And in the absence of a plan for how to move forward together, we move forward separately. So we're trying to just figure out how to do this aligning stuff. With that, I think we can break. It's plenty of time to break. Any burning questions before we break about the stuff we just threw at you to kind of give you that 30,000-foot view of how we're trying to approach this?
Dr. Clinton, I'm wondering if you could address, Eva had a question about where do the independent physician organizations fit in this? None of these slides reference the work being done by those groups.
Yeah, actually, they do reference it, but it's in the fine print of the last slide that we talked about. Anytime, any place, anywhere, independent physician organizations can participate in any of these community initiatives. And in Southeast Michigan, in Wayne County, we have had participation from independent physician groups, as well as Mobile Health in Wayne and some of the other provider organizations in the community to link up to a network of churches that we built called the Detroit Community Care Network to begin to do screening and referral for social problems. So this is an all-play thing. In Grand Rapids, there are some independent physician groups that have talked with the teams in HealthNet about participating. So every place out there where these things go, there's an open invitation, and with varying levels of success, there have been independent organizations who have signed on and participated. Does MyHIN see themselves as a state level convener? Oh, there's a huge question. There needs to be one. MyHIN's role and MyHIN's lane is in trying to work toward building out the standards so that people can join in. And to the degree that we're trying to catalyze these conversations, I guess we're the convener. I would love to have a separate body that the state can charter to be that convener to really take this on. Because MyHIN is about moving information, not about having community conversations as its core mission. All right. Other questions? Boy, we're getting great stuff here. And Brian, thanks. This is great, Brian. So read the chat. There are great questions here. Should we break now so that we can have enough time for people to talk? I don't want to talk anymore. I want people to talk.
I think I think that breaking is probably a good idea because I think that a lot of these chat questions and comments may come out during those facilitated discussions, and feel free, even if you've put it into the chat already, bring it back up. If it's, just feel free.
I think the facilitators are going to have their hands full if you all just want to talk more, please, because I'd rather just shepherd a discussion than ask questions.
For sure.
Okay, so let's see, whoever's doing this, Katie or Rachel, can you start breaking us into breakout rooms, please?
Yep, please hold, and you should be moved to a breakout room momentarily.
Thank you.
Transporting.
And Joanne, just as a reminder, you and your group are actually going to stay in this main session. So this is your group, just so that way anybody that dialed in could still participate in the breakout. So it looks like you have about 33 folks in here with you. So feel free to start the conversations.
I think you're muted, Joanne.
First, you might want to unmute yourself.
Oh, that was genius. I'll never be able to say that again. Gabe, do you have these slides for me? Sorry, hold on one second.
Yep, it looks like Gabe is working on pulling up his screen. If you can just give us one moment.
Okay. Okay. Here we are. Collecting the collection and sharing of social care data. So the first question I have for this group, hi, my name is Joanne Jarvie. I should let you guys know that I came to MyHIN boldly from a community-based organization. We were working on creating a community information exchange that was to be co-owned, co-governed by community-based organizations and by local government in Washtenaw County. And we had to try and figure out how to get information to flow. And I dug in. So I don't know much about your space, and I'm really looking forward to learning more. Can we move to the next slide? The first thing that we're trying to figure out is if there is an impression of the value of screening for social care needs from the healthcare perspective. Gabe, can you forward the, thanks. If someone wants to jump in, I'm wondering if there is a collective understanding or a collective valuing of having to screen for social care needs within your practices. Do you see the value of it from a healthcare perspective?
I'm Lewis. And we were a part of the original Greater Flint Health Coalition Shire.
Okay.
So we've been collecting SDOH data for a long time. And I think I'm not a provider myself. I'm a population health analyst. And my background, to be totally out there, my background is actually social cultural anthropology.
Amazing.
So for me, in doing the job that I do, I'm very happy to have that education and that perspective on healthcare. And it just happened to be where I fell into a career that I was surprised by. But I do believe that our providers understand that the social determinants of health really do impact whether or not their patients are going to show up for a visit, whether or not they follow through, the other concerns that will impact their health today, tomorrow, 10 years from now, and 20 years from now. I don't think there's any question among most of our providers on that. My biggest concern is, and it's not always easy to get people to share this personal, private information. And if we're going to share it with others, I do believe it will need to be with their permission, which obviously will prompt changes to our own SDOH surveys and how we collect it and how it's entered into our into the medical record or not. I'm interested to hear from others on the same topic.
Same, please tell me what you're thinking. We're here, we've got to get this on the record. We've got to give this to the state. We have to give this to the payers. So if you're going to say your piece now or forever hold it, really. I mean, why should doctors be asking people about their social needs?
I mean, I'm a doctor and I probably have not done a good job of asking. And I think the reason some doctors don't is because we haven't seen the questions translate into anything beneficial to the patient or to their care.
Tell me more. So you ask these questions, but then nothing happens, or you don't see the next step. You don't know how to easily provide them with a soft space to land.
Yeah, I mean, I think most doctors are well aware of the importance. They understand the role in the patient's well-being, but we feel powerless and helpless in doing anything. So we have pens and scalpels and things, and that's what we do. But you know, sort of you ask the questions, you document the answers, and that's it.
Right. Do you think one of the things that I found like so unbelievable was that like one of the demonstrations, the state innovation model demonstrations, and if you don't know much about the state innovation model demonstrations, I think that we have like some amazing people in our room right now that can explain them. But what was so interesting to me was that people screened positive for a need or a couple different needs, and then when the doctors asked them if they wanted help with those needs, they said that they didn't want help with those needs. And I wonder, sometimes I thought to myself, well, wait, were they asking if they wanted the doctor's help? Maybe they were saying like, yeah, I have these needs, but I'm not looking to you. I don't want to, it's none of your business.
I think there's far more people with far more knowledge about this than me, but I would say two things that in my population of patients that might lead them to say no is A, they don't know how to receive the assistance. They haven't had that kind of relationship before. And there's a stigma, there's maybe they're embarrassed. So I'm not sure that we always do it in the most sensitive, productive way that we can.
I would agree with that. I work for Great Lakes Physicians Organization. I'm the community liaison, and it really is how you present it.
Right.
I feel as though we give them a paper, they fill it out, but I mean, we have to handle these people with care, and it's not something they're used to. And when you view a doctor, I am not a doctor, but I view a doctor, you know, we have this, I put them up on high. I don't always want to tell them everything. I'm more concerned about even with your healthcare, like, you know, if I can see sometimes I don't want to tell them like I didn't take my medication all the way through with my antibiotics. I withhold that. I'll tell someone who I feel more comfortable with that, but I feel like I put the doctor on a higher level until and I don't think that's wrong. It's nothing that doctors are doing. But even when you're in school, I've heard doctors say, well, we treat symptoms. There's not always symptoms that you can treat for social. And we have to understand that people are struggling, and it does affect, because I've been able to help multiple people, and we've been able to know, we had a homeless mother of 2 kids, and they kept going to the ER with some asthmatic issues. Well, she was in and out of homeless shelters. Well, once we found her home and food, clothing, and shelter, they haven't been back. So, I mean, it's out there, but you hear the stories. We need the data to prove, and data takes time to prove. And so, and we also have, you know, especially with COVID, we are skeleton crews. People are exhausted. You need to hire someone else to do this. And how do you have the funding? And at the payer level, they don't want to pay unless, you know, at the payer level, they don't want to, you can't bill for all of this unless, you know, there's care manager ways, but social determinants of health doesn't necessarily associated with the care manager. Sometimes you have care coordination. And if there was ways of reimbursing these doctors for it, for what they're doing, even for negative testing, I think it'd be easier to get everyone on board.
I appreciate that. What about these Z codes? I mean, what are you guys, I mean, even for you, Melissa, you were the one you were just talking, right?
Yes.
Do you ever assign Z code diagnoses, or would that be on you? Like, where does that come into your practice?
So I'm a physicians organization, so we have multiple independent practices, and so we can tell offices, but we can't determine if they do it. So we're showing them to do that, but realistically, we have a bunch of different payers, and we have a bunch of different, I mean, if you've looked at Z codes, you can see homelessness, and there's 40 codes for each one. They almost need to have a cheat sheet of some sort. Give us the codes that you want us to use across all payers, make it a little bit easier, and then we can do that. But what if we use the wrong one, or they don't really, we need some guidance. And if we have the guidance, we can educate, but we need to know what to educate to our practices. We need to know how to teach them to do it or show them what to use. And we have 26 different EHRs or EMRs. Yes. And so not every single one is easy to pull from. So we have to sit down and figure that out and make sure it's in, and the Z codes are in appropriately. So it's a lot of work, and we're doing that. It's just a long road. It's not something that's easy.
This is Alicia. I have a question about the Z codes too, in terms of implementation. I'm from Michigan Medicine, and we've held off on implementing Z codes. One of the reasons is that we were worried about assigning a diagnosis to people that would stay, even though they weren't necessarily, even though it wasn't related forever. So if somebody is homeless and then they are not, it would still show up on their diagnoses as homeless. And I don't know who was asking earlier about, trying to solve the problem over and over and over again. There's no real way to sort of take it off your diagnosis list. So we haven't really been using the Z codes as much as our own internal data for that. And I wondered what other people thought of that.
We have the same concern, Alicia. I think as far as how do these.
Tell me who you are.
Oh, sorry. This is Mike Leeson with United Physicians, and we have the same concern as both of you, as far as we've got 49 different EMRs. Each one of them is handling Z codes and this information differently. But I think our greater concern is the longevity of the record and how we're going to maintain it. A lot of these a lot of the Z codes, while very descriptive, can be very short-term in nature. And I think we have a lot of concerns about applying one of those diagnoses to someone's medical record and having that carry for an extended period of time, even though it could be very inaccurate. Like, for instance, a Z code for unemployment is an option. So is it the expectation that the providers monitor that patient's employment status, and how are they going to find out if the patient has been employed between a visit, and how often is that record shared during that duration of time? I think having an understanding or a game plan as to how we're going to maintain these, so that when we see one, we know it's current and an issue that we can work with them to address is really, I think, our biggest challenge or concern in relation to SDOH data.
When you guys ask your SDOH questions, I want to hear from anybody else, even if it has nothing to do with what I'm about to say, but I just have a question. When you ask your patients these questions about their lives, do you think that they recognize that these questions are the same part, like are involved in whatever they signed for their HIPAA agreements? I guess, one of the things that I think is really interesting, besides the fact that there doesn't seem to be a good way for how to carry or move forward from a Z code, is that when community-based organizations ask people questions, they don't give them these large HIPAA statements. And I guess I'm wondering if you think that your patients know where this information is going.
So Joanne, this is Aisha. Hi, nice to see you. I'm actually so I'm a researcher over at the University of Michigan, and I did a pilot study where I asked this question to patients. So we're still working on the publication of this, so this is not out yet. But when we asked them their perspectives on social determinants of health screening and where they thought the data went and what they thought about this data being on EMR systems and consenting, many of the participants that we talk with, and we talk both in rural area and urban setting, they pretty much assumed that this was going into the EMR.
Okay.
However, they weren't very comfortable with it going into the EMR. Of course, it's not everybody that's uncomfortable, but it's a lot of people who are uncomfortable. Primarily because the reasons that were given were they're okay with their doctor seeing this information, they're okay with the doctor's team seeing this information, but they often don't know who else is seeing this information down the line. And so there's no control over their social information. And you know, the question that came up earlier about how long does it stay on the EMR was also a concern that was brought up. Like, if I'm homeless, is it gonna stay there forever? And is everybody gonna treat me later as I was homeless once? And there's a stigma associated with it. So from their perspective, right? So, and there were varying levels also of assumption that, you know, this should fall under HIPAA, or it should be more treated as more sensitive than medical information, versus it should be treated as less sensitive than medical information. So there is no consensus on the level of sensitivity of data that we saw, at least in this one particular study.
Yeah, I think I need to be clear that for right now, MyHIN, as the state designated entity for data exchange, we're working under we are working under HIPAA, right? So this information, without it being, and this is down the road. I'm sorry, I'm getting into. I just think this is so interesting. The governance. There was a question. It was sort of like, what are people intending to do with this data? What is MyHIN intending to do with this data? First of all, MyHIN doesn't do anything with the data. MyHIN moves the data. But also, who are they moving it to, and how are they using it, right? If they're using it to actively care for somebody, then that falls under HIPAA. So that's that. When you guys are doing, I see a question. Please just interrupt me. I think we should all be interrupting each other. It can be like my family. Just interrupt me. Hands up. Does anybody want to speak, please?
Yeah, thanks, Joanne. This is Alex Plum from Henry Ford.
Alex, you should definitely be interrupting me.
Thank you, and thanks for facilitating the conversation. I wanted to just share from our perspective, and the last speaker's research is incredibly compelling. We found similar work through our own process improvement with our patient advisory groups. Henry Ford is collecting this information. We are documenting it using Z codes. We're doing that because we have some value-based contracts with payers that have asked us to report that information out. I know obviously the Blues and with the new PGIP and the SDOH use case, that's going to be a big part of one of the uplifts for that as well. So we're trying to set this, notwithstanding some of the concerns others have raised, which we've well taken as, you know, as things to note. But as we've moved, you know, one of the ways that we've tried to handle this is we've built processes to obtain consent throughout the process so patients understand both because they're told verbatim and the way the data is collected, it's being provided like they provide the rest of their PHI. So, you know, Henry Ford's an Epic shop. We use MyChart questionnaires go out for all kinds of things, whether the PHQ-2. And by the way, when health systems started collecting PHQs, we started really making mental health. These same concerns were happening. This is really sensitive. I'm not really sure if I want this information documented. Is this the same as a medic? You know, we bifurcated behavioral mental from the physio, you know, structural medical. So we've had these conversations, and now of course we don't even have a question. We send the PHQ-2, the PHQ-9 out through MyChart. We do it in the clinic. It's the same role. The same way we send out, you know, questionnaire we're doing for social determinants of health, and it's the same role in the clinic that asks those questions and documents it in real time in front of the patient on the screen. The patient sees the screen, they're doing it together. So in that process, in addition to, you know, the couple sentences we say that we're explaining it, we let the patients know they don't have to answer the question, they can opt out at any time. That helps create the context by which patients understand for, you know, we're trying. You know, it's not a perfect process. Nothing in healthcare is. But this has helped us move that work forward. And, you know, the other challenge I'll just say about Z codes, and then I'll stop talking, is the Z codes do not map perfectly to the domains that we are addressing. You know, there are a lot of areas where the exact Z code is so nuanced that a screening question, yes, no, cannot even begin to get to it. And so we have to default. Generally, we have, I think, several, probably maybe 3 or 4 of our SDOH domains default to a broad Z code. And there is some utility in that. You know, I think some of that one person had a question around, well, how do you say that a patient is experiencing unemployment? How long does that last? Well, how long did the flu diagnosis last? You know, so there are ways to bookend those diagnoses in ways that make sense. But to some of that specificity, when it's so much, often we don't have questions to answer them. And so the mapping process between that is going to be something for us to continue to work on.
Absolutely. And I want to say on the flip side, you know, that reminds me of something. So when, I don't know if anybody here is familiar with 211, but 211 is a resource directory. It's a public utility. And when community-based organizations get listed in this resource directory, in order for call-ins or clients to be referred to these, you know, to these agencies. And by the way, that's been going on like by phone or by fax, or sometimes people are just given a list. But there are also these taxonomy terms, these AIRS taxonomy terms for what type of service or what type of service a community-based organization can do. And then within those AIRS taxonomy codes, it's like, yeah, we're a food pantry. But then you have to dig in deeper to say, we do kosher, we do halal. And a lot of the community-based organizations also just talking about the mapping. And this is sort of where MyHIN wants to be in. It's the mapping of the data. And this is all stuff this is really, really good conversation. Gabe, can we move into sort of referrals and workflow? Thank you. So, you know, information is being shared with payors. I'm wondering how many people on this call are currently practicing a process for sharing information with service providers, with social service providers. You know, how are you doing it? How are the referrals working? Are you screening everybody? And are you sending all of the needs? Give me some, tell me all about your good work.
This is Samantha from SDOH again.
Hi.
And again, we've had a few years of practice, and I definitely could understand the comment made earlier about providers being afraid to ask questions if they didn't have an answer or a way to treat a symptom. And we found that by having an in-house community health worker who reviewed the SDOH as it came in, and reached out to the patients individually in order to connect them with our community hub through Greater Flint, or directly to 211 or other services and CBOs in our community, that it made it easier for our providers to ask the questions, handle the surveys, because no one wanted to ask, are you homeless? And just shuffle that information somewhere. So our follow-up is almost all through either our behavioral health worker, who handles the anxiety, depression, and other issues like that, or through our community health workers who are really just contacting the patients with resources.
So when you say you're working with, who do you represent? What entity?
We are a provider hospital organization, and we have about 70 employed docs, maybe less, and another 30 to 50 independent docs who are just our primary care providers. So not everyone's on our EHR.
Right.
And so, you know, the information has to be collected and handled differently depending on which doctor is collecting it and submitting it to the community health worker. But we have, for a population of over 100,000, we have 2 community health workers. And they do stay extremely busy, obviously.
Yeah.
But it's hard to expand a program when there's no funding for it. And although, you know, there's little things available through the BBR uplifts, and it's not as if it's a code that's getting paid for, because a community health worker isn't a nurse or a PA or a PCP. She does what she does.
Thank
Are
you
other
for
people
that.
using those types of resources within their own provider organization?
This is Alicia. We will have a CHW trained person. We're trying to test out a pilot starting within the next like month or two in specialty. But I think we do anticipate if the CHW talks, the CHW would be able to bill the PDCM codes, the phone call codes, and if they're doing care coordination on behalf of the patient, they can also bill that as unlicensed. So I think we were intending to do that if we had the ability. But I'm glad to hear, it's interesting to hear how many you have, because we were just starting with like a part-time person essentially with a few clinics and hoping to expand quickly and pivot that to primary care if it worked in specialty.
Well, this is year 3 for us. So we started with just one CHW and expanded to the second. And then we added, because we saw the need, the behavioral health social worker. And then this year we've added a second behavioral health social worker. So it takes time. And I don't know that, as far as I know, we don't have billable codes for CHWs. Obviously, there's the uplift for providing the SDOHs and collecting them, but I don't know of any other things that they are billed. We have nurses that follow up with actual medical needs, transition of care from the hospital, but the CHWs are a program of their own as far as you know.
And how are they making referrals into the community? Are they using Greater Flint Health? Are they using Greater Flint?
It's a combination. It's not always the same problem. It's every patient is different, what they're comfortable sharing, how they want their information handled. It's entirely unique to the patient. And the one thing that is very nice about having a CHW is they're able to find out what the real needs are that need to be solved today and give them it's basically like having our own 201, but with actual names and phone numbers that they can reach out to in our own community.
And are you saying that because you feel like they have the relationships?
Exactly.
Okay. And but then after they have made the referral, do they follow up to see if these people have been served?
Generally they will speak with them if it's an immediate need like homelessness, no electricity, no heat, no food. Then they'll follow up within 24 hours to find out if they were given other options.
And are you putting all of that information then into? Is it going into an electronic system to document?
We are storing it all electronically, but how it's being stored and how much detail is included and it's not going into the medical record other than the SDOH was collected. I don't believe it's even in the medical record other than if they've given actual referrals.
Okay.
But the follow-up is scheduled just like a regular visit in our EHR system.
Mm-hmm.
I can answer on a PO level because we, like I said, we have so many different private physicians. So I am the community liaison. So I work for the PO, but we have multiple care managers, care coordinators, and like primary care and specialist offices. And then we have a screening tool, and most offices will at least make sure that they're screening them at their yearly visits. We educate and ask them if there's a change of circumstances. We talk to the MAs because a lot of the patients will talk to the MAs or the nurse or whoever's rooming them. And we even talk to people who are billing. If you are calling somebody because their bill is due, that's a good time to say, are there any other things that non-healthcare that you need? Because if they can't pay their bill, their co-pays, there must be something else going on. So we screen the patient, and we have a live binder, digital online, that would have all resources in every county. I'm part of every collaborative in every county and I'm on the 211 board. So we have a live binder for all of our offices that they can provide. I like to do warm handoffs, but that's not where we're at. Sometimes the care managers can do that, care coordinators can do that, but there are needs that are not met sometimes. If you have a homeless patient, it's beyond homeless. There's so much more that they need help with, and it can be overwhelming. Then the care managers or care coordinators reach out to me, and then I can assist them. But I don't work with the patients directly. That's for their healthcare team, because they have to build that connection and that trust within the healthcare team, so that they go back to them for help. Then that care coordinator, that care manager follows up. We keep a log of all of our positive. It's a Excel spreadsheet, but they just mark it down, type it in, then they fax it to me, and I have a database, and I input all of the data information into an Excel spreadsheet, and I keep it for that year. It's a lot.
I literally had to close my eyes because I just got really overwhelmed. Right. So I think, gosh, let's just say, for the record, to the powers that be, that there's room for improvement for you there, Melissa. Just in terms of the process, but it seems like you guys are doing the work. There are some other questions on this slide. I'm just wondering, when it comes to there's the referrals, and then there's knowing if the referrals have been, knowing what happens to a patient. Does anybody have a good process for hearing back from like the people that have received the referral, or the organizations that have received the referral? No good way. Okay, I think we're going to move on, Gabe, to this next bit of questions. All right. So it seems like, Melissa, for instance, you're taking this data. How are you using like aggregated data?
Well, we're trying to improve our process all the time, but how I'm using the data is I'm at the table with the nonprofits, and I can say per county, what are the needs that are not being met, or what are the needs primarily in that county, so that when they do get grant or they do want to start a program, I can advocate for our patients. That's what I'm using it for.
Mm-hmm. Is anybody else doing something similar? I'd love to hear about like the uses of aggregate data. We were talking about sort of like client specific, really getting into what's in their records, but like, how are people using or hoping to use aggregated data?
This is Alicia from Michigan Medicine. Right now, we have a dashboard that pulls up over all of our clinics what is the most frequent domain. And it had historically been social isolation for a very long time, but we added in virtual care questions. And it turns out the virtual care is almost 12% of our need. 12% of our population has a virtual 11.4 or something like that, has like a virtual care need, meaning they don't have enough internet, they don't have a tablet, or they're uncomfortable with the with having care virtual because they're just uncomfortable with the technology. And it's directing our efforts in terms of prioritization and what we have to work on with developing resources for our patients and knowing how to connect our patients. So it means that's where we put our efforts versus just sort of guessing or hoping that what we thought was true is true.
Mm-hmm. is there ever a time, when you look at a patient and because they are in a specific population? So I'm just going to go for it. So somebody's an older adult, right? And you see that they have, that there's like social isolation. Do you automatically, or do you automatically think of like the AAAs? Do you automatically think to yourself, okay, there's this person, there's this need, they're in this population, and this seems like the right next place for them? So instead of a hospital, Alicia, to your point, trying to find the resources needed to make people more comfortable within like virtual care, I bet there's like 3 or 4 other organizations that are also looking to help with that, depending on, what population this person falls into.
Yeah, I mean, for us, things like social isolation or interpartner violence, those are an urgent referral to the social worker at the clinic.
Social worker at the clinic, okay.
So their social work care manager would have a call with that patient basically like same day ideally, and try to understand more about that work, about that person's individual need, and essentially triage from there, whether it's connecting with a community agency or if it's some kind of therapy or like whatever it is that they might need, that's then put on with that individual who's more of an expert in that field.
Right. So that's where like that triggers your social work care manager.
Right. So it's supposed to, that's the flow that's ideal. One of the things that we're trying to do with our new dashboard is track the frequency with which the referrals are happening and being and not like resolved, but that the referral occurred and then the patient was connected with the intended referral end goal, right? So did they get connected with social work, or was there another referral that we were making like to our patient financial counselors? And so having all of the pieces of the process is important. Yeah, that's even in-house.
That's just in-house. Got it. Right. Can somebody else tell me, like, what do you think would be, I think there's so many, I haven't even gone through the chat. Beth, are you with us here in this room? Beth DeHart? I don't know if you're comfortable kind of reading out what you put in the chat.
Sure. Do you mean both of them or just?
Yeah, I'd love to get people talk. I just want to make sure that you wrote. I want to make sure that like your questions are being recognized.
Oh, thank you. That's kind of you. Well, there were just 2 thoughts really that occurred to me during the course of the conversation. One was I appreciated the comments earlier about concerns indicating a social care need in a medical record that may be temporary. And I was just like, oh, and I think it was mentioned again earlier, but just there are medical issues that are temporary by nature as well. Like, oh, I have poison ivy. Well, you're not going to have poison ivy forever. So I think there's an assumption in the medical record that poison ivy would go away eventually. And so I don't, however that's handled in the medical record, maybe the social care need or social need could be addressed in a similar fashion. It's just a thought. And then the next question, I really appreciated some of the comments that the medical care providers were making that clients are not especially comfortable with with revealing social care needs, what is going to get, what will be done with that information, et cetera, et cetera, et cetera. And, I appreciate that over, the course of history, when there has been a larger health need, I think smoking cessation might be a good example. Like there was an intentional public awareness campaign that was designed to tell the community at large, smoking's not good for you, so that it's not just a one-off, a one person to one person every time messaging strategy. It's more of a let's address the ethos of the thing and create a new culture around this particular thing. So I was wondering if there would be some wisdom there in maybe re-educating the world, if you will, about that this is a new strategy that healthcare providers and social care providers really are trying to work together. We're not really just trying to gather your information for kicks. We really want to address the whole person. And I don't know who that this idea would be addressed to, but I think it would be a neat challenge for somebody to say, hey, yeah, we do want to say to everybody in the world, we're trying to work together for your good.
Beth, I think, we can't take on the world yet, but I will be.
Darn.
Okay? It's just Tuesday. But I will say that, our sponsors of this work is the state of Michigan MDHHS. And I think that one of the things, just this idea that that the people that are responsible for your care, be they sitting in a doctor's office or a hospital or at Meals on Wheels, are trying to get together so that you have a team, so that you can build out your care map, so that when something, God forbid, you're an older adult and you're alone, if something happens to you, that we know through query, first of all, through query or through patient matching, that you have people on your care team that you could, that could sort of coalesce around you. I think that's a really important point that you bring up. We have 8 minutes left before we go back into where everybody comes back into the group. And I would love to be able to set you guys up to really say things during that time. Can you tell, what are you guys frustrated with? What is the frustration? Alicia, tell us what I know you guys have frustrations. I'm wondering if we could sort of get them recorded. What are your biggest frustrations? What are your biggest barriers? And who are you looking to for help? Where should the payers be coming in? Where should researchers be coming in? How much do you think community-based organizations can take on or should take on? A part of me feels like if people aren't comfortable answering the questions that you're asking, perhaps a good partnership with, the community would make more sense for them to do the screening. And maybe they already have done the screening. And maybe there's a way to go into a care team, an electronic care team record, to see some of these answers to move forward with treatment as appropriate. Give it to me. And if you don't want to give it to me now, I would really hope that you guys vocalize your frustrations, your challenges, but also the opportunities that you see for both MyHIN and for the stakeholders that support MyHIN, which I showed you, pharmacy and payors and the state. And also next week, we're having meetings with school systems. We're having meetings with the agencies at the government that are responsible for re-entry from our jail and prison systems, right? There's that whole other side. How do you work with school systems? Do you work with school systems?
So you've asked a lot of questions, and I'm going to start. I think one of your first ones, which was, what am I most worried about, basically, when it comes to social determinants of health? And I think we at Michigan Medicine, we have a lot of benefits that might make us different from some of the other groups. But I think similar to many of the groups that participated in the state innovation model, we do have a good process in primary care for screening. We screen 86% of our patients annually. And so I think that part is fine. It's really the follow-up and closing the loop that we're working on. And so we want to make sure that if we're asking people something that we are trying to work on the resolution for them if they want help. And one of the things that we're really working on is we just, our legal and find help, which used to be Aunt Bertha, but they've been working on getting us a contract for a long time. But what I want to do is make sure that we have a good connection with the community-based organizations. We have a lot of connections with them through the state innovation model work. But we don't have a good process, and and we're just starting down the road of talking with them about how do we share information about the patient so that we know if the patient actually got connected to the CBO. And I feel like we're right back at some of the sort of EHR and interoperability questions that we've been working on for so long. And I'm worried that that's going to be one of the challenges that makes it a problem to really know whether or not your process is resolving something, or as resolving something as far as we can go, basically, for people. And so I guess maybe out of this conversation, I'm wondering, Joanne or any others, if you have advice for how to connect with CBOs who might already have technology, and how do you connect in with their technology if you also are trying to develop a technology at your PO or your health system, and like with the new opportunities with connectivity with MyHIN, how does that all play out? I guess probably none of us have the answer, but that's kind of where that's where my thoughts are right now.
Miss Joanne, this is Beth Dehart again. Do you mind if I interject just for a quick second here?
Never.
Okay. Just as information, this is what I'm about to share. Some of the people on the call probably know, but maybe some don't. I don't know. But I just wanted to let everybody know that there is right now a competition that's being hosted by ACL, the Administration for Community Living, that is the Social Care Referrals Challenge, and it addresses this very thing. Joanne, you're nodding, so you probably know about it. So the concern that is coming up over and over in the conversation today is this very concern. How do we, in a meaningful and scalable way, build a strategy, technology-based strategy that will allow medical care providers and social care providers to communicate with one another reliably. So the competition is still going on. There are 3 phases of it. There are 2 phases that have already passed. The 3rd phase is starting. But the hope would be that I think within maybe the next 2 years or so, we would have some results from this competition, and that would be able to be adopted. So I just wanted to offer that there's a little bit of hope on the horizon. There isn't an answer yet, but hopefully it's coming.
Thank you, Beth. Yeah, I mean, we have an ACL grantee here. I don't know why she's not speaking up, but I will tell you that she's here. And I know that they're working through this. And I know also, Alicia, MyHIN is now partnering with Find Help specifically on interoperability. And we have, we're bringing a number of the vendors to the table in Michigan to talk about this. So this is what we would be responsible for. But I think one of the things that we need to figure out is what information does everybody need and why? What information can make a community-based organization more sustainable? And what information can make providers more effective? Sam, I see a hand up.
Yeah, I think it's really important that we remember the reality. Here in Flint, one of our biggest CBOs that actually solves some problems with hunger and homelessness and other issues as far as like needs for certain care is the North End Soup Kitchen, which is a Catholic Charities-based organization. And their computer was more than 15 years old.
Yeah.
So we had to actually provide them with a laptop. And I think we also had to teach them how to open it, turn it on, and email. They only have one director with a staff of 4. They're underfunded. They are not digital in most cases, and they certainly don't have a lot of room for building infrastructure. So I think that's a really important thing to say, and something to keep in mind as we try to, I mean, at this point, we don't even have a way to get information back into the medical record from specialists that are outside of our system. They're not in our ACO. We're not generally getting it back unless we happen to get a fax. And that's about 20% of the time. So if we can't solve that problem, I think this is going to be a little bit beyond that, because these are organizations that are even less funded than our primary care. I do believe that primary care is the right place for these questions, but I believe that pretty much everywhere people can go before it's too late or their problems get so big they're already in a CBO. That needs to be addressed. For me, I wanted to know if anyone else is using the SDOH surveys or information they're collecting in order to adjust risk scores for their patients.
So Sam, I tricked you because you were saying such brilliant things, but we were in the main meeting room. So now there's 120 people that think you're brilliant. Really, but I'm really glad because here we are, we're back, and we are supposed to be coming back together and really elevating, the stuff that came out. And Sam, that was a sort of, I think, a perfect transition. Thank you.
So for those of us that only heard the end of what Sam said, does she want to recap it? Because I like the end of it.
Oh, I don't even remember where I started.
It was a good place to start. Sam, you were like, listen, let's look at the realities. The soup kitchen, right, that serves, like most of our community, we had to give them a laptop. I'm not going to tell the story, but like you had to give them a laptop and teach them how to turn it on.
Yes. It was, I just wanted us to, as we were talking about using this information circle, I don't think it's as important for our organization to get information back from the CBO as it is for us to make sure that our patients get to the CBO. But beyond that, these are underfunded, poorly funded organizations that may or may not be ready for the digital age for another 10 to 20 years.
Yep.
And how they handle information at this point is not, I would not want them to have my name, number, or social security, just for safety. But I think that as long as, I mean, we still haven't connected the medical record outside of our ACO to other specialists and hospitals. HIE does a lot of that for admits, but we don't get whether or not they're attending physical therapy. We had a patient that was beyond stage 3 and in dialysis that we didn't know about for a year. So there's still huge communication gaps across the medical field, never mind to CBOs that are underfunded. And I also asked about the risk strat.
Sam, that comment, if I can comment, and I'm glad we're all back together because this is really, really important. That there's going to be a range of people's ability to connect to technology. And one of the things that was missing early in the national conversation about this was this point, and we brought it back. We brought it back to some of the national work that Gravity has done and some of the standards making organizations, because this is really, really important. And I don't want to leave anybody attending this session with the notion that somehow we're going to force technology down the throats of organizations that do one or two things and don't need to do them electronically. But we have figured out that our information sharing needs to accommodate participation of those sorts of helpers in community. And it may be that we will simply do things like understand that there's a group that just can't do this yet. We'll hold on that. We'll work with those that can. But really important point. And I think that in whatever phase 1 of this work MyHIN and the state do, we're going to have to keep that in mind. So we want to make sure that that gets pushed forward. Thank you.
Lisa, I think you're talking on mute.
Oh, I know. Yeah, Lisa, you're talking and your hands are moving. You seem so passionate. Nothing. Are you back? No, still can't hear you. No.
So folks, we are 120 some people who have been through an hour's worth of conversation. There have been so many ideas put forward and so many descriptions put forward in all the groups. Is it possible to have an open discussion now about these things that you see on the slide? You know, where do you think, we're asking your opinions here from your spots, where does this work need to go next? And what do you want MyHIN to try to do to make your world and your ability to do this work better? This is open season to leave us with the one big thing you want to get across at this. Don't everybody speak at once.
Since when has healthcare ever been this quiet? Come on. Beth, I think you're on mute as well. There is a muting function. Beth, can you hear, or can anybody hear me?
Yes.
Yep.
Okay.
Yes.
Beth, were you talking? So for those who are not able to be heard, I did find that if you kind of exit and come back in, maybe that's what's going on. Okay, so Jane says, this is not a technology project, and I just lost that thread. This is not a technology project. This is a collaboration project. I think that that is a great comment, and it does do even just nodding. Do people agree with that? Great.
But also, I mean, along with that, if I could challenge that for just 1 second, wouldn't it be great if we could also notify or sort of put the vendors that are moving into this space, this for-profit vendors moving into this space, competing to get people on their systems? Wouldn't it be great if while we are collaborating and while we are figuring this out from a workflow, you know, really from a clinical perspective, wouldn't it be great to get them on notice to say, look, in Michigan, in Michigan, we're not picking a winner. In Michigan, we are supposed to be vendor neutral. We want people to work on systems that work for them. But you should know that probably going forward, as these collaborations are happening, we need to work towards making sure that your systems are speaking with other systems. Like, I agree with you. The human infrastructure necessary, the conversations necessary, the convening. There was a really good point made in my group about explaining to citizens, explaining to human beings that there is this push. Nobody even knows what SDOH means outside of this, you know, explaining this. But I also think that when you have an open market for tech, the tech tends to take over. And I think somebody needs to come in and say, hold up. Here's what you have to agree to do in Michigan before you sign up any more disparate organizations.
Agreed.
I have a funny story about one of those tech companies that were working in a Wisconsin community. We had a provider group that invested close to $100,000 in a piece of software that would collect that information and do the follow-up with patients. But they had so little work done ahead of time, and they hadn't connected to the actual organizations that the patients were being referred to, that they ended up getting better information from the church groups who were passing pieces of paper with patients' names on them back and forth so that they weren't extending resources to the same person over and over again. those groups with their little lists and their emails with names, and the word confidential in the subject were probably, and were actually more effective than the technology that was way ahead of itself, and couldn't be used in that situation. And I know we're there here in Genesee County, so.
That idea that healthcare is local, social care is also very, very local and regional, and that that fabric that is woven together with, you know, statewide entities like, you know, AAA's or United Ways or things like that that are have that level of presence, but also within those very small community organizations that are very local, the mom and pop shops, and that are critical in their own right. So being able to weave those together at a regional level, exclusive of or in addition to that idea of technology, is critical. Ruth, do you, I'm not going to even attempt your last name, I'm sorry. Do you want to elaborate a little bit more on your comment?
Please.
Sure. I think it relates to stuff that others have just said. What is the actual follow-up when they're screened and their codes made and referrals made? But the people who are doing the actual work that may not have digital resources, like they are important stakeholders in this conversation about what actually happens on the ground. And it's important to get that input, and it may be harder to get than those who can't attend a Teams meeting, right? So that's my point. Does that make sense?
Yes, very much so. Thank you for that feedback.
Sure.
I just wanted to throw out there, if you guys are interested in, I would love to use this group really quickly. Next week, we're meeting with government entities and agencies. And I guess I'm just wondering, we were just touching on this. I asked like 17 questions and then everybody in my group got overwhelmed. So I really need to just slow down for a second. But is anybody here working with schools? Like, do you have a direct connection to your schools or to to organizations that help people reintegrate into the community after being in the prison system or jail system? Anybody working with the refugee population? I'm trying to figure out, you know, that government agency and entity portion is really going to be the kind of a wild card here, I think, because we're starting to get a lot of feedback from community-based organizations. How do you work with schools? Can you tell me if you do?
Beth, why don't you unmute and talk some? I think that.
So I think it's part of being in maybe smaller communities. We participate with our schools with behavioral health, and so they struggled with some of their behavioral health programs. And so we have at least social workers that are working in the school. Our medical director actually managed the MAT in the jail locally. So we do have some community contacts in that way. And I'm connected to the school because my best friend is the superintendent. So it's a small town and my husband's a teacher. So I don't think it's normal for POs to have those connections, but ours is maybe unique, maybe not.
But would it make sense though for would it make sense maybe for the healthcare providers? Maybe it wouldn't make sense for them to be in touch with these entities and instead make it so that the entities can at least speak with the CBOs. I mean, I don't know. I wouldn't want to leave anybody out, but I'm also kind of hearing like all we need to know is if people have been served. I guess, you know, I'm like, there's this talk about whole person care, and then there's also kind of like we only have so much time and we just need to know if like people are getting help anyways else.
I think when you talk to pediatricians, and I can see comments in the chats that, you know, how we work with kids, whether you're their healthcare provider, their mental health provider, or their education provider, there's so much overlap in getting a plan for families, and that family based care involves all of those groups. And so if you're talking about pediatrics, for sure, I think you have to include healthcare providers and community agencies because families are complex.
And each is working to address those issues, for sure.
I want to make a meta comment here just and see if I can get some response to that, if it's okay with the group. What I hear and what I heard from my team as well when we were in our breakout sessions is that there's a wide range of technology, that relationship is important. We just heard in this conversation how in some smaller rural communities, the sort of social care networks are known and the connections are easier to make, maybe informally or ad hoc. That's maybe testable. It sure is what people believe, and it's having done this work in other states and in smaller communities, there is a difference in how a small region approaches this big problem as to how a large, diverse region like Southeast Michigan approaches this problem. But underneath all of this is a changing model for how care is to be delivered from a relationship-based model that is informal, that doesn't require so much exchange of data, but just communication, to a more transactional model where we have systems of care and healthcare teams where tasks are delegated to many people and the list of people serving a person is larger. And somehow our model for how to do this work has to be flexible enough and clear enough to let those local solutions evolve at the same time as the larger solutions evolve. So our tools need to be simple. We're not trying to create some monster data collection process for everyone, but we're trying to figure out how to get information and communication where it needs to go. So what I would love to hear about is how you folks think about this, and whether those of you who are thinking really hard about smaller areas and how they work can advise us on how to do this work without alienating or making your work harder, and adding value in both of these disparate settings, the complicated system in a major metropolitan area to a local system. We're struggling with this, and everybody in the country is struggling with this, and we're trying to figure out how to handle this. So reactions, thoughts, if you have them, we'd love.
Okay, we'll see if you can hear me now. Okay,
gotcha.
Good. Thanks. So I think the key from my perspective is flexibility, but also creating standards that everybody can understand. For example, including the Z codes, but maybe narrowed down and mapped to the questions in a screening process, but also then a process where maybe there's an Excel spreadsheet that a food pantry might use that is mapped, and the questions and the follow-up are more simplified. And so having kind of an a la carte where there can be 4, 5, 6, 7 different ways you can get the data in, not really different than how we map data from an EMR. There's lots of as long as it's in a field that we can map to, we can capture it as long as that definition is understood. And so defining what buckets go into where, I think MyHIN is in a perfect position to help drive some of that. My providers will be much more apt to participate if there's some flexibility. EMRs aren't really set up for this. I think they're getting there, but if we can create a tool that can send that data and have it be understood instead of driven by health plans. Yeah, I agree with Jane. Start simple, don't boil the ocean. But if we can say, I'll just keep using food insecurity. Here's all the things that is under this food insecurity, and this is how we would define what goes in there. And it could be a Z code, it could be this definition of a screening tool. I think that's where it has to start. I think the vision to get farther down with measures and outcomes is great to have that vision, but we've got to start somewhere, and we can't even share the data yet.
I think having a person, a networking, I work as almost a human hub, so to speak, and I'm at the table. Like I said, we cover like 14 counties, so it's a lot, but I'm at the table with the trauma and the ACEs collaboratives. I'm at the faith-based collaborative. They help with childcare resources. I'm with the nonprofits. I can reach out at any point and call somebody and say, hey, I need help with this for my patient. And that networking with and having that person to call, they can help me. If I don't know the answer, I have 50 other people on this collaborative that can help me, but it's only for this county. It doesn't go, if it's in Bay County, if the patient resides in Bay County, we don't have that in Midland County. You have a whole nother set of networking. So it's almost like we need the same type of care across the board. We should be able to have one, one setup, one place to call. A hub is amazing where I know my Michigan now, mid-Michigan, has something in Midland like that where with the patients, they're set up with 211, and then 211 calls the patients to help. And then they keep track of the help that they have. The funding, though, for some of the nonprofits and to get that technology, like she said, you almost have to start small. And there are places that are doing it. There just needs to be the funding in order to make it bigger. But if you can start small and build, because everything is evolving, I think it will work better than some places. Even POs are not at that level, and they have these initiatives and they say, well, the money's there, but how do we get there? Like, yeah, the money could be there to help you, but we still have to, this is where we're at. And so I think we need to start there and meet people where they're at and places where they're at, instead of saying, we need you to get here, because that's overwhelming for anybody. And not everyone can get there, unfortunately.
Erica had her hand up.
There is a possibility, the mention of 211 is so robust within the community organizations, and they're already used to working with them, to really integrate this like Maryland has done into their model, where they're doing all of their referrals through their exchange network like this purposefully.
I can respond, Erica, to your comment. I think we are working actively with Michigan 211 to try to figure out their place in this. And I think we agree philosophically that having a resource that can be a very good directory for what assistance is available and to have it be statewide is great. Trying to get there is going to take some work. But yeah, but I've loved hearing this conversation, because there's such great thoughts out there from everybody, and including on this, including Eric Kelly. Yes, that's predicated on 211 being accurate. Exactly what we're having the conversations about. So,
well, we wouldn't necessarily be rebuilding a model. Maryland has done this, tested it, and so you would kind of have a playbook and what what worked and what didn't work, kind of thing.
And the interesting thing here, and kind of getting back to what Ernest wrote just in the chat, but what I'm hearing from everybody is that the solutions to what you folks kind of want to do on the healthcare side are you've been surprisingly open about saying we need to have better conversations, we need to engage, we need to work with where community organizations are at to make this stuff happen. And that to me is pretty substantial and enlightened for some other conversations I've had around the country. This is good, and you're right. This will have to be a partnership. We'll have to take into account what really matters to CBOs and how we can work with them. And that's kind of like Ernest's comment here. Ernest, do you want to unmute and talk a little bit more about that comment?
Yeah,
I think
no,
that's important.
Ernest is very shy, so I wouldn't put him on the spot.
Okay.
That's a complete no.
I'm kidding.
Go for it.
Yeah, Dr. Klinkman, I think you saw a lot of this when you were involved in the Shires.
Absolutely.
In Washtenaw. And, that's just part of the question here. Provider practices don't have endless time. They don't have endless bandwidth. They don't have endless staffing. And CBOs already have a lot. I mean, we have a lot of profiles on patients. We have a lot of data on patients, and they're often reaching out to us first about utility shutoff notice or transportation barriers, housing insecurity, new foster care placements. We already work with all of the school districts and homeless placement. We work with a lot of the refugee resettlement agencies with other types of instability. So, part of, I think, what would be interesting to explore is not just how providers get better at assessing SDOH data and referring to CBOs, but how you can already utilize all of the data out there that CBOs have that they can give to payers and providers.
And how to provide some support for CBOs for that part of the value that they provide to care. I mean, that's the flip side of what you just said, is that there's high value in what you already know, and you're connecting your already existing connections to people on the ground. And it's not a freebie. I think that's something that we need to use to support the work that the community organizations do here. So great point. And what has been really good to hear in small sessions and big is the interest of on both sides of working out and working together in these last two workshops. So we're approaching the end. Is there any burning issue that anybody else needs to get out there? Whether you just unmute and yell it out, or whether you put it out on the chat.
Yeah, and remember, this is being recorded and it's being shared with very important stakeholders. So if you feel like you wanted to make a call and that call was not going to be answered, pretend that you're making a call and that's really listening, because this is what this is for. So say it or forever hold your peace.
I'm hearing some crickets right now. So I'm going to make the assumption that we've talked everybody to death. So I think to kind of wrap everything up, I would like to say on behalf of everyone here at MyHIN, thank you so much for being able to take 2 hours of your valuable time out of your day to be able to participate in this discussion and really provide the level of feedback from people who are doing this work, this very important work, and how and give that feedback so that whatever future state is ahead of us is informed by all of these sectors. So thank you very much for being able to be with us today. We will be sending out the slide deck that you saw today. Those will come out first, and shortly thereafter, we will be getting recordings up on our website and allowing people access to those recordings, and a way to provide feedback about those recordings. So if people were not able to join today, they have a path to be able to provide that feedback. Or if you get home and go, geez, I wish I had have said what, then you have a path to be able to do that. So anybody else from the team want to say anything before we sign off?
Thank you all. We are trying to listen as best we can. If we don't get things right, please don't hesitate to try to correct us. This is really complicated work, even though we're doing simple things. So thank you all for your time and your engagement, and you'll hear from us.
Thank you.
Thank you so much. Take care.
Thank you.
Bye-bye.